Good afternoon, respected doctors. I'm Dr. Rohan, and on behalf of Brinton Pharmaceuticals, I welcome each delegate to this series of master classes in Vitiligo. We at Brinton continue to add value in continuing medical education through various educational initiatives for the benefit of medical fraternity. We had our first masterclass in the month of December 2021 on the subject of non-cultured epidermal cell suspension method. And it was followed by the second class in February 2022 on the subject of punch screen grafts. And we thank you for your encouraging participation in this both the programs where doctors all across India and abroad attended and appreciated our webinars. Today on the 11th of March, we are having our third session encompassing various important topics in the surgical treatment of vitiligo, which are ultra-thin epidermal skin grafts, blister grafts, and as well hair follicle melanocyte cell grafts. Apart from this, Dr. Giri Raj sir would be taking master classes in upcoming months on two more important subjects like medical therapy as well recent advances in vitiligo. Most of you would agree with me that many a times thought to be complex procedure can turn into be an easy one when some expert explains the same in a simpler way. And we have an ocean of knowledge in dermatology, Dr. Giri Raj sir, to make that happen for all of us attending this webinar today. We also have special presence of senior consultant and international authority on the subject, Dr. Giri Raj sir from New Zealand, as our guest speaker today. And I am delighted to welcome Dr. G. Ravichandran sir and Dr. Giri Raj sir for this today's webinar. I would quickly run through the introduction of both of the speakers. And before that I do that, I would like to run you through the all 6 master classes that we already had two subjects we are going to cover today, and the upcoming 2 are listed in the screen above you. And today we are having the master class on the topic number 3 and 4 as I described. And I would like to run you through Dr. Giri Raj's achievements. He has done his medicine from New Zealand and fellowship of the Royal Australasian College of Physicians, that is FRSCP, as well as he completed his post-fellowship training program between 2010 to 2013 in various acclaimed institutions like Royal Liverpool Hospital at Liverpool, then Glasgow Royal Infirmary, and London, UK, that is St. Thomas Hospital. Dr. Giri Raj has over 10 years of experience as a consultant dermatologist in New Plymouth, Wellington, and Nelson in both public and private institutions. And he has wide range of dermatology service exposure, including surgical dermatology, skin cancer treatment, phototherapy, laser treatment, aesthetic treatments, and all other core dermatology services. He is current member of the New Zealand Dermatology Society and secretary of the New Zealand Dermatology Society between 2019 and 2021. He has been organizer for various medical conferences in New Zealand and Australia. And he is on the editorial board and as a reviewer for the Australasian Journal of Dermatology. And after that, I would like to quickly run you through the introduction of our Dr. G. Ravichandran sir. And you all must be knowing that he is one of the leading and well-known vitiligo and pigmentary disorder specialists in India. His work spanning more than 35 years in the field of dermatology has been appreciated all across India and abroad. He has graduated from Madras Medical College in 1980, then did his diploma in dermatology in 84 and followed by MD in 89. He has been a postgraduate teaching faculty in the Department of Dermatology in Stanley Medical College for more than 15 years. And he has conducted many dermato-surgical workshops for the dermatologists and many CMEs. He has got trained under Professor P.N. Behr's Institute, Delhi, and also conducted many national and international presentations and publications. He has been co-author in dermatology chapter of Apollo Hospital's textbook of medicine. He has been conferred with Professor Dr. Patrick Yasuddin First Oration Award in Cuticon, Tamil Nadu 2015 on past, present, and future on vitiligo. He was awarded as the best dermatologist Chennai, which was presented by then Tamil Nadu Health Secretary, and has a special interest in vitiligo surgery and cutaneous oncology. He is a life member of various prestigious institutions like Indian Association of Dermatology, Venerologist and Leprologist, Association of Cutaneous Surgeons of India, Indian Medical Association, the Hair Research Society of India, and World Vitiligo Research Foundation, New York, USA, and has conducted many clinical trials with Apollo Spectra. So before I hand over the introductory section to Dr. Giri Raj sir, I would like to tell you that after the session, we will take as many questions as possible if the time permits. If you any of the questions remain unattended, you can mail your question on the mail ID of Dr. Giri Raj sir. That is RAVISKINDOC, that is raviskindoc@gmail.com. Now, I would hand over the session to Dr. Giri Raj sir.
Thank you very much. Well, really, this is an exciting international presence and amalgamation of vitiligo, which really vitiligo patients are often told by their doctors, in fact, that it isn't a big deal and that nothing can be done about it. And I really think this is a disservice because these people often arrive at a dermatology clinic, often discouraged after years of disease progression. And really the big thing here is vitiligo is not just a cosmetic disease, it's more like a psychologically devastating autoimmune disease. And the fact that treatments are available, I think, is very important for everyone to know. And it's fantastic that India is leading the way in this, and I'm very grateful to be part of this group and to understand and learn about the surgical treatments for medically resistant, often segmental vitiligo, that Dr. Ravichandran is leading the way. And what's fantastic is how the world now has to learn almost from India. We only do 3 or 4 surgical treatments per year in Australasia, while I understand it's happening almost at a weekly or daily basis in India. And also understanding the epidemiology, this is 0.5 to 2% of the world's population get affected by vitiligo, regardless of race and gender. So even though we may not see it too much in skin phenotype 1 to 3, or it's not as clinically obvious, it still has a presence, but of course much more psychologically and clinically devastating in the Indian subcontinent and skin phenotype 4 onwards. And before handing it on, really, another important point is 50% of the world's population by 2015 is likely to be skin of color. And that's even in New Zealand, Australia, America, places that are primarily Caucasian skin type, where there's a big change, travel and the modern world. And so 50% of the world's the patients that present to a cosmetic clinic, to a dermatology clinic, will be Fitzpatrick skin phenotype 3 and above. So the work with vitiligo and really skin of color is becoming more and more, not just an Indian issue, but really an international issue that, again, the world can look towards India to learn and grow. So this is actually a picture of myself learning under the great guidance of Dr. Ravi, who's presenting today, and really, again, portraying how amazing and fantastic it is to come to a vitiligo institution. And here in New Zealand, we tell these patients or clients, we can't treat this, but to actually come and see disease-resistant, segmental or focal vitiligo, medically resistance, that Ravi and his team are able to not only bring hope, but actually bring clinical results. And I think, again, just fantastic to see how we are now looking towards India leading the way in this topic. And of course, we hope to not only learn from Dr. Ravi, but also perhaps grow and continue his legacy for the years to come. So maybe with that, I'll hand it over to Dr. Ravi to actually enlighten us a bit more on the complexities of the surgical treatment.
Thank you very much, Dr. Giri Raj. Very nice to hear your version, and we appreciate your joining us today because it's going to be late evening, but our time. But anyway, we are happy to be a part of this program today. We thank from my side, and of course, Dr. Rogan will definitely proceed with the further resolution.
Thank you. Thank you.
So thank you, Dr. Giri sir. And as Dr. Ravi sir said, that thank you for taking your time out at this odd hour and accepting our request to be part of this program. And I'm sure the delegates attending this webinar would get enlightened with your insights and knowledge on the subject. Now I would formally invite Dr. Ravichandran sir to initiate the webinar session, sir.
Yes, thank you, Anandal. I'll just start sharing my slides. Give me a minute. Yes. Is it okay, Rogan?
Yes, sir. Perfectly fine.
Thank you. Thank you for your kind introduction, and Dr. Giridhar's summing up what is happening in other countries too. My topic will be on bringing the color back. This is a very interesting, catchy word. I think we will be talking to you about the surgical aspects of this difficult topic, and of course, subsequent lectures I'll be doing on recent advances on medical. The single melanocyte, which is derived from the neuroectoderm, is unique, and it travels far off from the neuroectoderm to home into the epidermal basal melanocytic area, as well as into the hair roots, to giving you the typical color features of our skin color. So we will be discussing about how do you manage this lost cell. This cell which is producing the melanin during the course of its probably we do not know the reason for its disappearance. Probably it's because of the autoimmune phenomenon or some other factor. Now new theories have come, but our job is to bring back the color on the depigmented stable vitiligo. To begin with a small definition, is the most common disfiguring depigmentation of the skin characterized by acquired white patches with an unpredictable course. Very apt on that. I'm saying that because this is a very unpredictable disease where it can become well with treatment, or it can even relapse after treatment, even after surgically. So this is a very good definition that all of us, as Dr. Giri Raj was telling about how far it is not only a cosmetic, it also got a small impact on their psychosocial outlook. It has got a wide clinical spectrum. The vitiligenous patches appear everywhere. It doesn't spare any part of the body. As you can see in the left picture, it's got a segmental vitiligo over the lip as well as above the lip margin, with all the hairs got depigmented. This is a very interesting observation. This shows that the hair follicles also lost its pigments due to some factors of autoimmune phenomenon. So this is segmental vitiligo. We have the acrofacial vitiligo. Though patients, we do see these patients stabilize themselves with the lips and acral tips, but they can also become a widespread non-segmental vitiligo. So we classify vitiligo into segmental and non-segmental. Mind you that we do see a lot of this segmental vitiligo where it doesn't fit in with any kind of a description called post-inflammatory depigmentation or hypopigmentation. This is a hair color, hair dye, PPD-induced depigmentation, which can come after leather chemicals or post-burn. Dr. Giri Raj was telling about PI, post-inflammatory depigmentation, following burns, scalds, or any kind of an event. So this is another just to show you, but we can do program vitiligo surgery for all these patients. Before we proceed into the subject of surgery, but we should understand the basic pathomechanism of vitiligo, which involves a chronic loss of melanocytes in the areas of depigmentation. The macules could go through two stages. The first stage is reversible with partial melanocytic loss. This is a normal skin. You see lots of melanocytes here, dendritic cells, and you see this. This is the first stage wherein some of the cells get disappeared. So this is a partial melanocyte loss. So that the medical treatment is very effective in this stage. The second stage will be irreversible with total loss of melanocytes, as you can see in the picture, where there is absolute indication for the surgical option, which we are going to choose in different techniques to bring back the color. Various current the current surgical modalities has been defined very well from our Association of Cutaneous Surgeons of India. So we classify them at the tissue grafts and the cellular grafts. Tissue grafts, we have the thin, ultra thin split thickness graft, which I am planning to demonstrate today with the video clippings and procedure. How simple it is, any dermatology, young postgraduates or anyone can start doing that in the outpatient clinic or in a theater-based procedure. Suction blister grafts also is very easy, and select indication is there, which I will be explaining to you today. Last time we did the many punch grafting session some few months ago, and today I will be demonstrating you on hair follicle grafts, which are also very useful because the hair follicles contain rich reservoir of melanocyte stem cells. Coming to the cellular graft, which is the most popular and the best procedure of late. Though I started with punch grafts and ultra thin, nowadays we always started doing this cellular techniques called non-cultured epidermal cell suspension. The cultured pure melanocytes are also I'm planning to start shortly now because it involves a lot of effort, and also on ethical grounds we need to be satisfy ourselves before we proceed to do the culture. The cultured epithelial grafts and the autologous non-cultured extracted hair root sheets. This is also very interesting, which what we are going to do today. So before you plan for a surgery, so what one has to think about it. Several points should be considered and discussed with the patient, because patient's expectations may differ and your outlook may be different. You may not give you 100%. Patients will ask you whether can you just give me 100% success rate. So sometimes we need to assess properly so that gives a good coverage as well as to a confidence to you as well as to the patient. The patient should be clearly explained about the nature of the procedure, the expected outcome, and the possible side effects. The choice of surgical intervention should be individualized. Depends upon the type of the vitiligo, which I showed you in the first picture, whether it is a segmental or non-segmental vitiligo. Classify them. It's very, very important to put the patient's vitiligo in the proper classified slot. Then the stability is also to be important, because before you proceed to do a surgery, one has to assess clinically whether the patches are stable. Stability can be a universal stability or a lesional stability. Dr. Somesh Gupta always insists on lesional, as well as both Dr. Devendra Prasad and Dr. Somesh Gupta are pioneers in these procedures. That is, they are good friends of mine. We learn from each other. Sites involved, as I told you in the first picture, any site can be doing this procedure, because the sites are chosen, but the criteria here, some sites do very, very well. As I told you, segmental vitiligo response is very good with any type of procedure. The acrofacial are very difficult. Lip vitiligo can be done. Genital mucosal vitiligo, all this can be done. The only question, as I told you, assess the stability. So how do you assess the stability? You can do a small mini fallible as mini punch grafting, which I explained to you last time, so that we will know exactly whether the punch we are transferred retains the pigment and starts perigraft migration of melanocytes, so that you can proceed to involve these new techniques at a larger sessions. Localization of lesions is considered. Cost effectiveness of the procedures, because it can be done in outpatient in kind of a teaching government institution, because the cost factor is not going to be very high, particularly might use a little more in the case of culture melanocytes and cellular transplant. Coming to today's topic of ultra thin epidermal skin grafting, we talk about this as an epidermal grafts, superficial skin graft, SSG. Then name is given ultra thin epidermal grafts. Any names will suffice, because we are going to take the top layer of epidermis, which contains only the basal melanocytic layer. Do not include any dermal component. The indications are absolute indications of segmental vitiligo, focal vitiligo, acral, and mucosal vitiligo. Pre-operative evaluation is properly done. A consent form to be signed. Preparation of the donor and recipient sites is most important. And what are the instruments you require? You need a small dental micromotor called hand engine. You need to have a diamond burst in the form of any country will have a Robbins instruments from USA, or our Indian manufacturers produces different shapes and size and quality. We have a fine, coarse, and medium of diamond burst. We attach it to the straight handpiece of the micromotor. Or if you do not have access to diamond burst, you can always get a diamond rasp from the ENT. You can go to the hospital, get one from the ENT consultant in the hospital. Or if you do not have, just buy a small hand dermabrasion, which can easily be autoclaved or sterilized. You require a skin grafting knife, which is called Humphrey's knife, or a lot of available in the theater. And always I prefer to do with the simple shaving blade. We sterilize it, autoclave it, and do an sterilization. We need to hold these shaving blades in a straight long cams. A dressing tray, surgical tray, we all familiar with that, containing buffered normal saline, cups, and then drapes, and fine scissors, and spreaders, and mosquito forceps and scissors. Tule dressing, bactigrass or a sofratili or any tule dressing will very important after you cover these grafts. And most important is one has to get a transparent collagen sheets. I would prefer to advise you on to getting transparent collagen than a regular one, because it might absorb the cellular material which we are going to transfer it onto the depigmented area. Procedure is generally done under anesthesia. Since it's an outpatient procedure, if you have a good time, so that you can apply this topical eutectic mixture of anesthesia called EMLA cream under occlusion over donor and recipient sites I always prefer more than 90 minutes to 120 minutes, because this gives you a good and topical anesthesia so that you can do a minor procedures, including a skin grafting and dermabrasion. Particularly younger individuals, hypertensive individuals, children probably use it for at least minimum 2 hours in whichever area you're going to do. And or if you give a local xylocaine infiltration, local anesthesia, or call your anesthetist if the patient is having a difficulty in coming over to the table and maybe anxiety is there. You can also sedate them, give them anxiolytics, and ask your consultant to give you general anesthesia so that you will be more comfortable if you wanted to do a large patches. The skin grafting is generally taken from the outer upper quadrant of the gluteal surface, front of thighs or lateral aspects of the thighs, and retroauricular region. I have my own reservations in taking the areas from thighs and gluteal in a young girl because it can leave, though the procedure is doesn't leave a scar, but it will leave a small pigmentary changes which is permanent. So try to choose an area which is covered, and retroauricular regions is a very useful technique because you can either a shave graft or a punch graft. So the scarring is obscured behind the ears. You can also mainly useful for a melanocyte cell transplantation. Demonstration dermabrasion is performed with, as I told you, with your instruments on the particular patches till uniform pinpoint bleeding is achieved, and do not go deeper than needed, because it might leave results may be very good, but it will leave a textural alteration that the procedure must match the surrounding skin and the pigmentation and the quality of the skin. So I would recommend you to use small superficial abrasion with a pinpoint bleeding. I'll be demonstrating you some of these procedures which is done under topical EMLA. The ultra-thin graft is harvested and spread over the dermabraded vitiligo patches. They involve the second stage. These taken out grafts can be put in a buffered normal saline in a sterile cups so that it can easily be transferred later after doing the dermabrasion. Dressing is to be done with a transparent collagen with a white paraffin tule and a gauze and a micropore plaster. It should be removed. Patients can be given an anti-course of antibiotic if you want to do a large area, and analgesics and pain management is taken care. And dressing is to be reviewed on the 7th or 10th post-operative day. The general instructions are typed and given to the patients because important is this post-operative instructions play a major role in bringing out a good outcome. Follow-up treatment is also needed. Most of the time may not require, but sometimes if you've done an extensive, there are areas of leftover depigmented patches, you might do a narrowband UVB phototherapy, or you can also suggest little excimer laser weekly 2 sessions for a period of 2 to 3 months. I'm just going to give a small view on how this is done. Please watch. Yes, this is taken from a right upper outer quadrant of gluteal after 2 hours of application of MLA. I have used a sterile shaving blade, which run through in a zigzag fashion from your elbow. And once you start trying this, it's very easy, because this is a very useful for both this ultra thin graft on vitiliginous patch. Also, this is also very useful for the non-cellular, non-cultured epidermal cell suspension. You can use this to prepare cell suspension too. So this is a very interesting technique. Please, most of the young bright postgraduates must try and experience yourself to getting the top layer of epidermis, because this is an art. Once you learn the art, you'll be very happy to proceed well in further on your patients. And you can also try this on a small, take a small good tomato and start doing the same technique, peeling the top layer of the tomato skin if you don't want to straight away jump to on the patient table. So this is a very interesting one. This is taken out and kept it in a buffered normal saline in a sterile cup. And the patch is, you have a segmental patch, as you can see here. This has to be dermabrated uniformly using a hand sanitizer, straight hand piece. You can use different shapes and sizes of this diamond phrases. You can use a small pear-shaped one which doesn't cut through the skin, particularly around this angle of the mouth or any difficult areas. You can use a different coarse grains, fine ones. The coarse diamond grains are useful for a thick patch or maybe phototherapy-induced poor keratotic patch. Sometimes you may not be able to do dermabrasion very, very well. So this is a very important. Always, please, before you start treating these patients on the sun-exposed areas, give them a good amount of sunscreen so that there is not much of photo damage in the skins. And the donor graft is spread on to the skin. Yeah, this is after doing the dressing, and after this 2 months or so, you see a uniform color pigmentation, but you do see leftover areas of depigmented skin here and there. And this is a small segmental vitiligo, including the leukotrichic hair, I think years ago in the topical. This is after the 7th day, the ultra thin grafts are placed so that it is taken. This is a small dressing which adds as a small adhesive, because you don't have to, because we have done the dermabrasion confining. Maybe you can go a little beyond the white patches, because to prevent the peri-halo phenomenon, so that you can extend your procedures like that. So this is a thought-provoking thing which we always say, how do you tackle these complications? Complications do occur, as you can see here, small, not complications, but the pigment migration is not happening to a great extent. Of course, it has happened here. Even this is a photograph taken after, say, maybe 6 months or 1 year later. The white hairs also started getting deep repigmentation. That's been retrograde migration of the pigment cells have happened. This is a very interesting, simple technique for small areas of focal and segmental vitiligo. This is another patient I did long back. This is also called, this is ultra thin, really good ultra thin, the young girl. But these are small islands which are left, which can easily be managed in the subsequent sessions, either by a mini micro punch grafting or with another melanocyte cell transplantation. If you just try to work up this patient with a post-operative, maybe a month later, you can start narrowband UVB or a excimer laser phototherapy. Coming to the topic of blister roof grafting, what are the instruments you require? You require a suction blister units are commercially available, or you can use a disposable 20 ml, 20 cc syringes with a 2 or 3-way adapter so that we suction so that the air doesn't leak out. Donor area application is generally done of the suction cup is done and syringes done, and preferred because it is going to be there for a period of 1 to 2 hours to get a nice big blisters. So please, pain will be there. So that please infiltrate small 1% xylocaine under the syringes. You can see a nice blister of coming every 15-30 minutes. Please examine the inner aspect of the suction cups so that you will know when to remove these syringes. And then after that, you need to remove this blister roof by a small thin forceps and a 15 blade or a small mosquito scissors, and put it on a glass slide or in a small buffered normal saline. You can also put it on your finger, and the patch is dermabrated, which like I showed you, and transfer the blister roof skin over the dressing and keep doing the regular dressing for these patients. You can do it for, preferably this is ideal technique for mucosal vitiligo, particularly lip vitiligos, as well as for the genital vitiligo. These are the two absolute indication for the blister roof techniques. This is how we apply the syringe, and use another normal syringe, remove the air column inside, and use the stopper to close it and leave it so that it doesn't fall away. As you can see, there are small blisters coming up, and maybe it took more than an hour or two to get a nice blisters here. Sometimes you see a monooctar or multi-locus. There are 2-3 blisters may be there. That inject a small buffer normal saline into this area of blister, so the skin whole blister become a large one like this. And with a small iris scissor and forceps, you can remove this top layer of skin, because the underlying skin will be containing only the basal layer of melanocyte. So you can always transfer it to this. Suppose if you are not even familiar with for ultra thin graft for the non-cellular culture technique, you can apply this blister and use this blister roof for preparation of the melanocyte rich cell suspension. So there's a simple, just on the table, you can always plan change your program. It's something like a patient is taken for a stenting and finally converting into CAPG. It's something like that. You can decide it, but always explain to this patient that this may be a problem which we may face. We might start doing a different technique. Please have some small photographic evidence so that the parents or the patients can be shown in a simple way, not alarming their psyche. As I told you, the lip vitiligo is the most important thing for them. So start dermabrading with the hand dermabrade or micromotor with the dental bar till uniform pinpoint bleeding. Lip bleeds a lot. So that is why, but it stops after a few minutes. So you can clean it the area with a normal saline and then apply the the blister roofs there and apply it so that you can cover it up with that. The dressing material, like as I told you, the transparent collagen. Very new findings I'm doing now, because it's the most difficult condition to stay these grafts on the lower lip. Patients cannot have their food or open the mouth, brush the teeth. So that is why I prefer to do it. I might give a small nasogastric tube or an intravenous fluid, but this transparent collagen has given a good way because it adheres and seals this area. I learned this small dressing, Dr. Bell. My memories go back to New Delhi Scan Institute School of Dermatology. He asked us as a postgraduates to do this type with a cotton ball and dip it in collodion flexible. So flexible collodion is taken in a gauze and put the cotton, spread it onto the grafted skin. Place the cotton swabs, the cotton, and apply this collodion flexibly. It dries up and seals like a cement. So after 7 days, you have to remove with an acetone. Professor always say, make a window and I will come and see whether it can be removed. So we make a small windows by using acetone to destabilize this collodion flexible. And if it is very good enough to adhere to the dermabrated side, we completely remove. Those are the days of learning. So every day is a learning art. So what I do, I sometimes used to do a small 6-0 prolene stitches at the edges, but that's given up. Then we do a small dressing with bactigras and regular dressing. But whatever you do, the patient comes on the 3rd day, taking the whole dressing, and the graft will be inside the dressing removal pads. So make sure it is placed very well. Because we need at least around 72 hours to adhere the grafts onto the dermabrated area. Going on to the topic of hair follicle melanocyte keratinocyte cell suspension, this is similar to your non-cultured epidermal cell suspension. But here, what we are, instead of a skin taking away a patch of skin, you start taking a small hair follicles. So what are the instruments required? If you have a good hair transplantation set kit, you can always use them, or you can use a skin punches with a 1 millimeter diameter. It's a very simple, easy technique under local anesthesia. But if you have a hair transplantation instrument with a micromotor hand, then you can use a 0.8 millimeter punch, like what we do it for HT, hair transplantation, both donor and recipient harvest. Like xylocaine infiltration anesthesia is the most important because topical don't work there, and we need to do it generally from the occipital area. Hair root isolation of 25 to 50 hairs are done, taken, and put it in a buffered normal saline. It is to be incubated in similar like your non-cultured epidermal cell suspension, 0.25% trypsin EDTA solution over more than 90. I required more, sometimes 90 plus 60 minutes. We need to do 2-3 passes. It's not one pass. You can't separate the cells. It's very difficult to isolate and separate the keratinocytes and melanocytes from the outer hair root sheath. And the separation of hair follicle melanocytes and keratinocytes is in Dolby-Coast Eagles medium and aspirated in a 1 ml syringe and then centrifuge it. You can also prepare it with the centrifugation technique. So when you isolate a small, the quantity of melanocytes, keratinocytes from the hair follicle, which also contains the stem cells of the hair follicle melanocytes, here very small quantity. So that's a very interesting finding but it has got a potential to multiply and spread more than what your basal skin melanocytes. So that is why we always combine these two. You isolate your hair follicles and then isolate your skin melanocytes and then combine both and start applying on this dermabrasion vitiligo patches. If you wanted to do a large area, particularly in the facial vitiligo, say maybe we have to do more patches, say 20 centimeters or 30 centimeters, this will be a good option at a program. So this is similar equipments which require for this hair follicle melanocyte cell isolation. We require trypsin EDTA solution here, 0.25. This comes from a laboratory called Sigma Labs. And then this is trypsin EDTA inhibitor to reverse the action of the trypsin. And take ml of this, add this here, and then incubate it, and then add after this separation occurs, it becomes a little puffed up so that it's easy to separate the cells, and put it in a small petri dish, and then start putting little of these Dolby-Coast Eagles modified medium, which is contains growth factors, which is a culture medium for even we do this for the culture, and then start separating in the area with the thing and transfer it to with the pipette. You can isolate and discard the remnants of the hair keratin as well as the skin cells and put it in a small test tube so that you can take it for a centrifugation. 1 ml can be taken and it can be centrifuged so that you have isolate the cell pellet. And this is small steps by technique. So prepare the area, cut the hairs and then seal it, and use a 1 millimeter punch and harvest these punches here on the small petri dish containing buffer normal saline. You see many are just isolated here. So there are these, just as I told you, when you incubate it, preferably in these chambers, you see these are small chambers we use. It's available in the laboratory chemicals equipment company. So we just put it here, add the trypsin EDTA here and put it in the incubator and start trying to find out whether they are all getting swollen up. As you see here, they are all tiny rods, and now it's all puffed up, and so that means we can always isolate and separate from the dark hair keratin. After it is done, transfer it to the pipette as told you like this, and then spin it in a centrifuge 3000 RPM for a period of 5 minutes. And this is, of course, I have taken the skin melanocytes like this is a cultured epidermal cell suspension here. The pigment cells are brown colored, and this is a little lighter in color. They both contains the epidermal basal melanocytes as well as the hair follicle basal melanocytes. We can always mix both together and put in a 1 ml syringe and spread on to the dermabrasion. Yeah, this is how we do. The patches are dermabrasion, and the cell suspension is sprayed onto these areas. You see here. and keep ready your transparent collagen so that there is no dribbling and wastage of this liquid material. Yes, you can always see here nicely. It just adheres and then also acts as a collagen sheet. It's a transparent collagen. Sometimes, yeah, you can see here nicely. You can still centrifuge it so that you can take a. What will happen? Suppose if you add more thicker, darker cell suspension, the depigmented patch will get a good repigmentation, but it will be of a darker shade. So make sure that you do not over enthusiasm. I have learned so much of these complications because I don't want to leave and throw the melanocyte cell suspension. We just pour it on that. When we have observed that these patches started getting more darker, patient is very happy, but says, doctor, see the skin matching is not, the color matching is not there, doctor. So the most important complication, we cannot reverse this one, the pigmentation has come. So make sure that the desired amount of cell suspension is placed onto that. Okay, even if it is left over, you can store it in the refrigerator so that you can use it at the subsequent sessions, or maybe 1 or 2 days when you remove the dressing, you can always redo it. I don't know the viability of this cell suspension refrigerator. I do not know. A kind of thesis can be given to postgraduates to all the cultural characteristics or isolation characters of the cells, which I have done long back before I started venturing into this. So as I told you, this technique involves dermabrasion of the vitiligo patch, transfer of the hair follicle cell suspension over the vitiligo patches. It can also be mixed with non-cellular, non-cultured epidermal cell suspension to give an enhanced result. Dressing is to be done as the regular dressing. Thank you so much. Vitiligo patients are just differently colored. Let us add color to that line. Thank you very much.
Yeah. Thank you, sir. Thank you very much for sharing an excellent session on the important surgical methods. So before I hand over the session to Dr. Giri Raj sir for his concluding remarks and before I make my vote of thanks, we would like the couple of questions that have come on our way. I will combine a common set of questions. The question has come from Dr. S.K. Punshi sir and also from Dr. Praveen Kumar. So basically the crux of the first question is that is the punch skin grafting in vitiligo can be considered safer as compared to this, or can it be compared like the safety profile of these grafting techniques? And another question is that is the hair follicle graft better option among these all four grafting which we have seen so far?
A very good question. To begin with, you can all try with the mini punch grafting. As I told you, now mini micro grafting 0.8 millimeter is the choice if you want to do large areas. It also gives a more or less equal results like your ultra thin or a non-cultured epidermal cell suspension, but involves time. No, so it is more time. You need to spend more time, and the results are not as fast as you see in other procedures. That is the reason that we always moved out from mini punch grafting. Small areas, as I told you, can be done even idiopathic gutted hypomelanosis. Also, you can do a mini punch grafting. The program of these punches also can be used to separate the cells, because cobblestone formation, scarring, as I discussed with the last session, avoiding conflict, because patients wants good color match, the textural quality of the skin. They should know that you have done any kind of a procedure at a later date, maybe 3 to 6 months down the lane. There should be a good, as if this doctor has done a skin grafting there, they will really wonder. Even that is why this we prefer to do, because sometimes polka dot, sunken pits, keloid scars, the color mismatch, perigraft migration may be delayed, it may not be uniform. To avoid all those combinations, the technique. But if you're a beginner, please start doing mini punch grafting to learn, so that you can step by step, you can advance. I started with mini micrograft. Now I am into cultured melanocytes. It takes as Dr. Devendra always say, from it takes a big flow. No, so you need to remember that it's you define your expertise at a later given session.
Great. Thank you, sir. So another question that in sensitive areas like maybe lip or the mucosal areas like maybe genital areas, okay, is there any chance of disfigurement while doing this blister grafts, or any special precaution needs to be taken in these kind of areas when we do this blister grafting?
Yes, lip vitiligo blister grafts are ideal because it is more or less secured place, whereas in the genital mucosa, particularly men and women, and this may not be a very valid one because it might slide, it may not peel off. So that is, though we do a proper dressing, so that is why we prefer to do a cellular suspension technique in these areas. But what I have off late started doing is I start doing cell transplantation, as well as on top I do a small ultra thin graft, so that I want to doubly make myself sure that the grafts take up much better. You can also do step by step. It's not that you want to do the whole lips at a given stage. Maybe try it out in one angle and then proceed with other areas.
Okay. And there is one more question from Dr. Anil Mishra, sir, that he wants to know that among all the three methods which we discussed today, is there any chance of recurrence, or how is the priority thing that the less chances of recurrences are with which method?
Yes, very important. As I told you in the patient selection, stability is the most important criteria. Those listeners, stability for a disease of 1 year wherein there are no new patches, there's good repigmentation, that can be easily taken. So if you're still worried about it, take 1 or 2 punches of 1 millimeter, put it on to this vitellogenous area, wait for a month or so. If it retains and perigraft starts pigmentation, perigraft migration, then it's a stable vitiligo. You can proceed to do any type of procedure. Every procedure is very useful technique in the management of surgical management of vitiligo. It is your experience, interest, and the expertise which gives you excellent coverage, because we know this is how we can be doing it. So we categorize these patients. This is the best technique for punch grafting, like you would say, periareolar macule over the breast, nipple and areola. We know that punch grafting are the ideal one, and these are the ways by which we identify. Thank you.
Great. So before I make my vote of thanks, sir, I would quickly hand over the session for brief concluding remarks from Dr. Giri Raj, sir.
Thank you very much. Fantastic, Dr. Ravichandran, for sharing those insights. And I think, beautiful to know you're combining the cell suspension and the blister grafting on top. So I'd be interested to see where that leads, and are you getting better pigmentation? I was interested to know, do you put the blister graft first and then the cell suspension on top, or the other way around, or it doesn't matter? And also your comments about over pigmenting the skin by putting too much epidermal cell suspension. So I guess I'd be keen on your comments, if not now, in the year to come, to see how you get on. And of course, combining the cell outer root sheath from the hair follicles with the epidermal cell suspension. Again, three concepts and techniques that, of course, we don't know in out of India, so that's fantastic. Definitely worth staying up all night for to get these pearls of wisdom. We still only do 4 very basic cases per year, so to see the wealth of knowledge, and you seem to be doing these frequently, almost on a daily basis. And really my last comment to the viewers out there, whereby again, segmental vitiligo, perhaps the hypothesis, or one of the hypotheses being it's a local field of somatic mutations in these abnormal melanocytes, hence making it resistant to medical treatment, because these abnormal melanocytes can't repigment. So even phototherapy, even the biologics that are coming out. So hence making the validity of these surgical treatments where you're transplanting normal melanocytes, or a different pool of melanocytes, into these areas that can't repigment, I think is always going to have its treatment choice in this vaster subject. So thank you very much, Dr. Ravichandran. And again, we hope that this can be in the future a nice international amalgamation. And thank you for inviting myself.
Thank you, Dr. Giri. And Dr. Ravi, sir, we are truly delighted after listening and watching you explain the surgical procedures. There were multiple procedures today, but excellently in a very simpler way, you could explain the ultra-thin epidermal skin grafts, then blister grafts, and then hair follicle melanocyte cell grafts. I am very sure that after watching you explain this procedure, many of the young budding dermatologists would try their hands in experimenting these techniques, and that's how they will be mastering this technique, and that's how the use of these techniques will be broadened. Having said that, we also would like to thank Dr. Giri Raj for sharing his knowledge and insights and perspective on the subject, and taking his precious time and I would say compromising his sleep time to be with us during this program, because it must be about 11:30 p.m. at his place now. And we thank you from the bottom of our heart and from the behalf of Brinton Pharmaceuticals. And we are sure that doctors attending today's session would have delighted and to listen and watch explain Dr. Ravichandran and Dr. Giri Raj their insights. And on the next session, we shall be updating the date and time of the next masterclass in due course of time. Till then, I take your leave and wish you all great health and success ahead. We'll meet again in the next masterclass, most probably in the month of April. Thank you very much.
Thank you, one and all. Viewers, please feel free. If you have any questions, please ask, and then I'll be very happy to train as well as answer your questions. And of course, thanks to the whole entire team of Brinton and Dr. Rogan particularly. We had a lot of effort. This is because it has to run well. And Dr. Giridhar and myself, all thank you so much. Thank you very much.
Thank you.
Thank you. Good day.
Thank you. Good night.
Good
Good night.